Hi everyone, this is Dr. Brittany Todd at Sacred Heart Clinical Pharmacy Specialties, and I just did a video on statin medications and their benefits. Now, to be fair, I want to go over the risks of statin medications because there are. Every medication has risk-benefit that we want to assess, and every patient is different. Every person responds differently to medications. Not everyone needs certain medications, but there are certain populations that do. So let's talk about the ones who need statins, unless there is a significant, what we call a contraindication to a medication, a reason we cannot use that medication. If they don't fall into that, if they don't have a contraindication, these people should be on a statin. So anyone who has heart disease, anyone who has had a heart attack, a stroke, a stent, a bypass, a mini stroke, they should all be on a statin, no question. Anyone over the age of 40 and who has diabetes should be on a statin medication. Anyone who has a cardiovascular risk score of greater than 7.5%. Now that's just looking at you specifically, looking at your family history, your blood pressure, your cholesterol numbers, do you smoke, do you not, how much do you weigh, certain risk factors that increase or decrease your risk of having a heart attack and stroke. If your risk is over 7.5%, that means that in the next 10 years, you have a 7.5% chance or higher of having a heart attack or a stroke, so you should be on a statin. And then the fourth population who definitely should be on a statin are patients who have an LDL, which is a measure of cholesterol, people who have an LDL greater than or equal to 190 on 2 or more occasions. That means that genetically their LDL and cholesterol is just very high. And we should put you on a statin because we know that the higher levels of cholesterol increase your risk of heart attacks and strokes. So those are the 4 populations that there's no question they should be on a statin, unless there's a contraindication. But for the most part, most people don't have a contraindication. There are some gray areas, what we call primary prevention. You've never had a heart attack, you don't have diabetes, your cholesterol is kind of in that middle range where it's a little bit elevated but not super high. There are certain patient populations where we might put you on a statin because your risk is a little bit higher. Maybe your calculated cardiovascular risk score is not over 7.5, but you're kind of at the 5% or 6%. Maybe you had a coronary calcium score that came back just a little elevated. There might be other times where we use statins, for sure. But those 4 populations we definitely want to use statins in. Now, there are risks to using any medication, right? What are the risks for statins? Now, statins actually are very well tolerated. People may not realize this because they hear a lot of people saying, oh, don't take a statin. I don't like statins. I heard bad things about statins, or my mom didn't tolerate statins, or, you'll hear all sorts of things. The only reason you hear that so commonly with statins is likely because there are millions and millions and millions of people on statins. So at some point, you're going to know someone who's on a statin who probably had a problem. So let's talk about what those problems could possibly be, but again, are pretty rare. Let's talk about the most common, what we call myalgias. They're muscle aches and pains. You feel achy, you feel tired, your muscles hurt. If it's statin related, it would be all over your body. It wouldn't be just your hand. I started taking a statin and my hand started hurting. Just the one, not statin related. You probably have something going on with your hand, which you should probably look into, but not statin related. Statins generally cause generalized muscle aches and pains in your big muscles, like your arms, your back, your thighs, your calves. You just feel achy. Some people feel weak. I'll hear that a lot. I started taking a statin. I feel like I can't really do as many things. I feel weak. When I'm at the gym, I'm not using as high of weights as I used to be using. I just feel kind of weak. So if you do experience any muscle pains or weakness that you are concerned about, talk to your doctor. Don't just stop the statin, talk to your doctor. There are things we can do. So in the studies, only up to about 10% of patients said they had muscle aches and pains. But we found that in real life, about 30% of people have muscle aches and pains. That's pretty common. That's almost 1 in 3 people on statins have muscle aches or pain or weakness or that sort of thing. So we definitely take it seriously. the good news is there are 7 different statins on the market. And really, it's most because people don't tolerate some and tolerate others. Like I said in the last video, most people tolerate all of them. So it doesn't matter, tolerate all of them. But some people, maybe even up to a third of people, have an intolerance to 1 or more statins. So what I generally do as a pharmacist is there are 2 kinds of categories of statins. There's some that get in the muscles and some that don't. We generally use the ones that get in the muscles just because they were less expensive for a long time, generic, they have great data. That's what we were using, which is fine, and most people tolerate it. But if you are having muscle aches and pains on the ones that get in the muscles, it makes sense to use the ones that don't get in the muscles. So we can easily switch you to a different statin that you'll probably tolerate. Another solution is if you're having muscle aches and pains on a certain dose, we can try a lower dose. A lower dose may not be as ideal because the higher doses do have that heart attack and stroke prevention, so do the lower doses. But we know that the higher doses are a little bit better at heart protection. But if you're having muscle aches and pains and it's, impacting your life, you're thinking about stopping your medicine altogether, of course we would just decrease the dose. Let's try that. We've also tried alternate daily dosing, so maybe take it every other day or once a week. There's even still some benefit with taking these medications not every day. Again, I'm not advocating for you to make this decision on your own. I want you to talk to your provider. Ideally, the best statin regimen is high dose every day. That's the regimen that has been shown to be heart protective. So if you're taking statins, you want to take it at a heart protective regimen. What's the point, right? I'm always saying, who cares if your cholesterol is high? Who cares if your plaque is stable? Who cares if you don't have inflammation? Who cares, who cares, who cares? If it's not actually decreasing the risk of a heart attack. So if you're taking a statin, my goal is always to take a statin that lowers your risk of heart attacks and strokes. That's the best thing you can do. So ideally, I work with people to find a statin that they tolerate and a dose that they tolerate. So muscle aches and pains is the main side effect that I hear from patients. Again, it's generalized muscle aches on both sides of the body and those big muscles. It's not just one spot, like my arm started hurting when I started the statin. Probably not the statin. I also didn't mention this, but when you have muscle aches from statins, they don't get better with medicines. So if you're taking ibuprofen or Tylenol and you feel better, that's not the statin. Something else is going on. We also have to remember that as we get older, we get achier, right? A lot of people have osteoarthritis. A lot of people are just, as you get older, you get achy. So just being cognizant of, are you achy before the statin or after the statin? Is it worse after the statin? Just being a little more aware. One thing we do watch out for, it's extremely, extremely rare, but the reason we care about those muscle aches and pains and we want you to tell us about it is because statins can, again, extremely rare, and it's not just statins, there's other medications that can do it too, they can actually cause muscle breakdown. And that breakdown product gets into your blood and then it filters into your kidneys and you can urinate it out. If you have brown Coca-Cola colored urine and muscle aches, that's not good, and you need to call the doctor immediately to figure out what's going on. If you can't move because of muscle aches, you're just like, I can't get out of bed, you need to go to the ER immediately. Again, incredibly rare. It's almost like as rare as having an allergy to any medication. You can't foresee it, but there are lab tests that the physicians can do that we can make sure it's not causing a problem. So muscle aches are the biggest side effect. Let's talk about the liver. A lot of people are concerned about liver because statins do, most of them, go through the liver. They work in the liver, right? That's how they lower cholesterol. They tell the liver to stop making cholesterol. So they can affect the liver. Really, there's only one statin that really affects the liver to the point where we do at least monitor for it, and that's atorvastatin. All of the other ones we're not super worried about. Atorvastatin at the highest dose is the one that we actually do monitor a little bit more for, but the FDA has actually said that we don't have to monitor for liver function tests anymore because they found even at the highest dose of atorvastatin, the incidence of having liver toxicity from the statin is the same as the incidence not on a statin. So yes, we have seen in the studies that people on the higher doses do have slightly bumped liver enzyme tests, but most not statistically significant or clinically significant. You might, go from an ALT, which is a liver enzyme that we test, you might go from like 20 to 40, but you're still within the normal range of under 50. So most of the time we don't monitor for an ALT, which is that liver test, although we do check it on occasion, especially if we have some medication interactions that we're watching. We might be a little more cautious about it, but we do tell our patients, if you ever have any symptoms of what we call hepatotoxicity or liver toxicity, you need to follow up. So if you have unexplained nausea and vomiting, if you have right upper abdominal sharp pain, that may indicate liver issues. If you have dark urine, if you have really light stools, like white stools, would indicate a severe liver problem. Again, extremely rare, so rare the FDA says we don't even have to monitor for it. But I do think people do get a little worried about their liver. Now, if you have fatty liver disease already, there's actually data showing that statins improve fatty liver disease. So there might actually be benefit for liver, and there's very little harm. I do hear people say, I don't want to take a statin. They just had a heart attack, right? And they say, I don't want to take a statin because of the liver risk. And I say, well, I'm more worried about your heart than I am about your liver. Your liver never had an issue. It's very resilient. Liver regenerates. It usually comes back from damage, especially if it's just an acute thing. It just was a really quick damage. Obviously, over long term, your liver gets damaged if you remain on something or you're drinking alcohol. But if it's just an acute thing, it usually goes back to normal pretty quickly. Your heart, on the other hand, has a problem. You have a heart attack. You have tissue that died. You have to be on a statin for your heart. So out of the two, if you're going to take the risk to your liver and the benefit to your heart, I absolutely side with the heart. Unless you already have underlying severe liver disease, I generally side with the heart. So, you got to weigh those risks and benefits. So we talked about muscle aches, we talked about the liver. I hear about memory. That's a new thing that's come recently. People have heard that statins can cause memory concerns. So this is true. There are patients, never seen in any of the studies, never reported, but there are case reports, several case reports of patients saying, I started the statin and I started noticing that I can't remember things like I used to. I forgot where my keys were. I forgot to go to an appointment. My wife has noticed that I'm not really paying attention anymore. I seem kind of foggy. There are case reports, and this can possibly happen. The good news is every single case report is fully reversible once you stop the statin. So if you're worried about memory before starting a statin, don't, because we can always stop it and see if it gets better. Again, the biggest concern for me is your heart and protecting your heart from a heart attack or protecting your brain from a stroke. Something I like to remind my patients of is dementia. The number one cause of dementia is stroke. So I recommend taking something that decreases stroke, which is the number one cause of dementia. Now, like I said, fully reversible when you stop the statin, these memory concerns, which means they do not cause dementia. They do not cause Alzheimer's. In fact, there's data showing that people who take statins have a lower risk of developing Alzheimer's. It's an associated risk, but they found out that people who have Alzheimer's were less likely to be on a statin before, versus those who don't have Alzheimer's were more likely to be on a statin. So we do think that there's some correlation of benefit of being on a statin to reduce the risk of Alzheimer's disease. And we know that they decrease dementia because they decrease strokes, which is the number one cause of dementia. So the risk for memory with statins is short-term memory loss, fully reversible. The other thing, like I said with muscle aches, is there's 7 different statins. Some get in the blood-brain barrier into your brain, some do not. So if you're on one that makes you kind of foggy, try the other one. We can always work together to try to figure out what dose is the best. The last concern that I hear from patients is diabetes. I heard statins cause diabetes. Now, this has actually been shown in recent statin studies that patients who take statins do have a higher risk of developing diabetes. However, this is only in patients who are already at risk to start. So if you already are obese, your blood sugars are already in that pre-diabetes range, just a little bit higher than normal, but not quite in the diabetes range. If you have family history of diabetes, if you have poor diet, poor lifestyle, those risk factors for developing diabetes, those are the ones that statins, yes, could push them over the edge of a diagnosis of diabetes. If you don't have any of those risk factors, you're on a statin because your cholesterol is high, but other than that, your weight's good, you eat well, you don't have diabetes family history, you're not already in that pre-diabetic range, you're not at risk for diabetes. It's not going to push you from normal to diabetes. What it does is it pushes people who are already kind of at that threshold to diabetes. And really what they found is all of the people who were here anyway, right at that threshold, were going to be diagnosed with diabetes anyway, regardless of the statin, because they did these studies for 3 to 5 years. All of them ended up getting diagnosed with diabetes at some point, or most of them got diagnosed with diabetes at some point. It's just the statin users developed diabetes or were diagnosed with diabetes just a little sooner. So about 3 months earlier than they would have been diagnosed without the statin. So what I'm saying is diabetes is a possibility with statins because statins do slightly increase your sugars, but it's only a concern if you're already at that threshold where we might push you over the edge. Now here's the kicker. People with diabetes are one of the 4 people who need statin medications because people who have diabetes don't generally die of high blood sugars. Some can, but most die of heart attacks and strokes. And what reduces heart attacks and strokes? Statins. So it's a kind of a catch-22 in some people's minds. If I start a statin, I might go to diabetes. You're right, but you need a statin anyway because of your heart. And now you have diabetes, which means you need a statin even more, right? Like you needed it anyway. So statins to me, again, it's that risk versus benefit. We might push you from a blood sugar of 123, which is normal, to 130, which is well, I wouldn't say it's normal, 123, which is pre-diabetes, to 130, which is diabetes. The statin push you up 7 points with your sugars, but you need the statin for the heart benefit. And you were probably going to be diagnosed with diabetes soon anyway. It just sped up that diagnosis by about 3 months. I get the concern because a lot of people don't want to be diagnosed with diabetes. I absolutely don't blame them. So what I tell them is, I'm putting you on a statin. You're already at this risk threshold where you might push into diabetes anyway, and the statin might push you over. So what I encourage you to do is not just take the statin, but I need you to eat healthy. I need you to lose weight if that's one of your risk factors. I need you to make sure that you are doing everything you can to prevent those sugars from bumping higher. So those are the main side effects or risks of statin therapy. So all of them, like I talked about, muscle aches, yes, they can happen, but we can definitely work around it and find the statin and dose that's best for you. We talked about liver, which, again, most of the time not concerned about at all. We talked about memory concerns. Again, the benefit far outweighs the risk, and then diabetes, again, benefit far outweighs the risk. So we know the benefits, we know the risks, and for most people, not everyone, most people, statins are definitely the way to go.